Hi, everybody, and welcome to the Mind on Mental Health podcast. My name is Andy Dean, and I'm a licensed clinical social worker. Today, I'm speaking with Dr. Susan Murray, supervising psychologist at Penn Medicine Princeton Center for Eating Disorders. On this podcast, Dr. Murray and I discuss what it takes to build a great eating disorder program and how she went about doing that at our new PHP-IOP program in Princeton. I hope you enjoy the episode and find it helpful. Hey, Dr. Murray.
Hi.
Thanks for coming to talk to me today.
Thank you.
It's actually the first time we're meeting.
Yeah.
Never
before.
How does it feel? You're disappointed?
No, not at all.
Can you just tell me a little bit about who you are and what you do for Penn and
Sure.
sort of your trajectory in this field and how it landed you here?
Yeah.
Thanks.
So I'm the supervising psychologist at Princeton Center for Eating Disorders, which is an inpatient unit dedicated to the treatment of eating disorders. We have 22 beds, starts at 8 and goes all the way through the lifespan. So we treat kids and adults primarily with anorexia nervosa, but we also see sometimes patients with a condition called ARFID, sometimes patients with bulimia nervosa. And so I essentially oversee the therapy team, which is composed of 6 social workers. They provide individual therapy every day to our patients who are on the unit and run groups for patients on the unit. And so I'm kind of responsible for that and clinical decision making on the day-to-day. We have morning rounds every day and get to see how each patient is doing, make sort of nimble changes to their treatment plan. So yeah, that's sort of what I do on the day-to-day. Trajectory-wise, I received my PhD at Temple. I was working with a woman there who specialized in the treatment of eating disorders and had several different training opportunities in the eating disorder space at UPenn, at Drexel, and then went out to finish my training at the University of California, San Diego. So I did my clinical internship there at a treatment center dedicated to eating disorders. It was a partial hospitalization and intensive outpatient program. And did my postdoc there, was hired as staff psychologist, and then had the opportunity to come out back east, which is where I was raised with my family. So
awesome.
Yeah.
Well, welcome.
Thanks.
And nice to meet you.
Nice to meet you.
Okay. I guess I wanted to ask you, I know that you've been, so the eating disorders unit has been at the Princeton Hospital for
30,
I think Becca just said 30 years. But we just recently started the PHP-IOP.
Yep.
And I understand that you were heavily involved in designing that program.
Yeah.
So, like, what philosophy is driving the decisions that you made in terms of setting that program up? Yeah.
So first, there was just a clear need that there needed to be a step-down program for our folks who are inpatient. So they're with us 24/7, right? They're getting so much support, both therapeutically and around meal support, things like that. And a lot of them would unfortunately go from 24/7 care to really maybe 1 or 2 hours a week of seeing a dietitian and a therapist, right?
Yeah.
And maybe seeing their doctor once a month. And it was very difficult for them to sustain the progress that they had made inpatient. And so we would see this sort of revolving door where folks would do quite well with us. They would go out and just have very little support and come back to us about 6 months later. And so it was important to me that we had a program that could help step them down into their life. So they're integrated into their life and they're home with their families or they're starting to work, but they're also getting a fair amount of structure and support. And we could catch maybe a little bit earlier if things were not going well. And so that was part of the impetus, was just seeing that pattern. And then I have had the experience of working at a PHP-IOP that was really stellar out in San Diego. And so wanting to bring that to this area as an opportunity for folks who are in the community who don't need inpatient level of care necessarily, but are not making a lot of progress just seeing a therapist once a week. They need more meal support, more structure, an interdisciplinary team. And so they would have an opportunity to come either to the intensive outpatient or the PHP level of care.
Yeah, and I think, unfortunately, that's something that's common across diagnoses in the mental health field. Like, inpatient is so structured, and then to go from that to 1 hour a week of therapy or counseling or seeing a dietitian or whatever it is, it's just such a shell shock at the time.
I know, and I think it applies across diagnoses, but there is something a little bit specific to the treatment of anorexia where there needs to be, generally speaking, a lot of support around meals. And so even if someone has the best intentions for doing well, having that extra kind of support around making sure that people are choosing calorie amounts or portion amounts that make sense for their body is, I think, a really important feature.
That makes a lot
treatment.
of sense.
Yeah.
You had mentioned like wanting to build a stellar PHP program. And I guess I was just curious, in your opinion, what are the building blocks required for that?
What does that mean?
We talked a little bit about, Becca, about like what the different levels of care are. But I guess I was hoping to get from you a little bit more information about like what we're doing differently or what would make our program stellar.
Right.
You know, and set us apart.
Yeah. So one piece is that it's basically a program where folks are getting, meal and snack support, but they're getting also a lot of group support with different types of therapeutic modalities. So the idea is that not everyone's mind works the same, right? And so having a program that just has one modality, I don't think is ideal. A lot of programs will be like, we just do kind of through this lens, right? We do treatment through this lens.
Can you give me an example? Tell me which program really sucks.
Yeah, no, that's not it. I think that every modality has a lot to offer, but we know that, again, people's minds work differently. And the way that my mind works now is hopefully different than how it worked 10 years ago, right? So we're getting people at different phases of life, and we want them to be able to connect to a therapeutic framework or skill set, and maybe they get something from CBT that they can apply to one part of their life, but DBT that is really helpful for another aspect of what they're struggling with. Or they are exposed to like an ACT-based framework, but could also really benefit from some of the skills from RODBT. So I wanted to make sure that we had a lot of different therapeutic modalities. It's kind of like a menu of a lot of different options, so that no one is leaving the program feeling like they haven't learned something that they can apply to their life. The second layer of that is that I think a lot of treatment centers will say, we treat eating disorders and we use different modalities, right? But they will introduce the concepts of CBT, right, for example. And there's a little bit of guesswork or kind of cognitive work that patients and therapists have to do to make those concepts or skills relevant to the disorder that they're treating. And so I wanted to build this curriculum from the ground, bringing all of these modalities to bear, but really tailoring them to the process of recovery from an eating disorder. So there's no extra guesswork involved. It's really tailored to the diagnosis.
So I want to make sure I totally understand what you're saying. It sounds like what you're saying is that other treatment centers at times might give people a basic idea of how to challenge a thought from a CBT perspective, right?
Right.
And then just kind of leave them with the basics without really a clear understanding of how to apply that to an eating disorder, like in an eating disorder framework, I guess. So can you give me an example of like what challenging a thought in CBT might look like in a broad sense versus what you tried to do with the eating disorder program, and how to like, I guess, put some color in there in terms of how to apply it from an eting disorder perspective. Does that make sense?
Yeah. CBT is a difficult one to
pick any of the modalities.
Okay. The only reason I say that is that I find personally that ACT is the framework that I most
I agree with you.
Resonate with in terms of the treatment of eating disorders, because what we see a lot with CBT, and it's not that it's not valuable, because it is, but we see a lot of folks who will say, okay, I know that this is an irrational thought, but it's what I believe. And so then we have to work more at the kind of belief level, right? And a lot of the ways that we're changing beliefs is through experience, right? And so a lot of the CBT work ends up being more experiential. So a little bit less on the challenging of the thought, though that's still valuable, but
more on the behavioral
level. But so for example, with an ACT framework, we would think about some eating disorder behaviors as a means by which someone is engaging in experiential avoidance, right? Like leaving what will be a very difficult experience, or trying to protect themselves from what is going to feel very difficult. And so we will talk about experiential avoidance, right? What that is. And then we will talk about how that shows up on the day-to-day with someone with anorexia, when and what kinds of things we can do to orient towards the present moment differently, and to support ourselves through what will be a difficult experience. I don't sugarcoat that the process of recovery will be very challenging. And so that we need a lot of skills and tools and supports to do it. It's challenging and it's worthwhile.
So can we flesh this example out a little bit?
Sure.
How might someone with anorexia nervosa engage in experiential avoidance?
Yeah. So just an easy example is, their friend invites them to come to brunch, right? And they're like, that was not part of my plan for the day. Like, I have a very kind of routine plan and pattern of how I am going about this day that is throwing me off. So there's kind of two options there. One is I decide to say, no, thank you very much. That's really nice. But maybe in the future we can go to brunch, right? So that's an example of like, I'm now opting out of a social event because of my disorder to stay feeling like safe and kind of in control of the way the day is going to go. Alternatively, someone goes to the brunch and they have a lot of difficulty remaining present because they are so preoccupied with thinking about what is this, what am I eating? Is the person observing what I'm eating? Am I how is this going to affect my weight? All of these things, right? And so that's another kind of moment where you've shown up physically, but it's really in body only, right? You are having a whole nother experience that kind of is removing you from the present moment. Another example is you go to the brunch, you're able to be present, that's wonderful, but it's going to then change the way that you eat and exercise or engage in purging behaviors for the rest of the day. So there's kind of all of these pathways by which someone might be avoiding the fact that I'm going to eat something that might make me uncomfortable. That's going to be an exposure for my fear of weight gain, and I might engage in all of these behaviors to try to keep myself from the uncertainty and the fear that this is going to affect my body. And so that's where we would start to think about like, okay, let's talk through the fact that if we are in recovery, we are going to have to be engaging in the full exposure, not just going and eating the thing, but also staying with all of those thoughts and feelings without acting on them.
That makes sense. It sounds like it sounds like something that was important to you in terms of this curriculum is like, instead of just giving them the definition of experiential avoidance, is making sure that they can then apply it from an eating disorders context in that way. You can give examples like this or analogies or whatever it is.
Exactly, to really flesh it out and make it obvious how this framework or skill could be useful to them in this process.
Okay. Thanks everyone for tuning into the podcast. Join us next time as I talk to Dr. Murray about the treatment philosophy that drives the care at our PHP IOP and how she incorporated that into training our therapists who work on the unit. We'll see you next time.